Hello. So I think it's safe to say that majority of the audience has seen a video or a post on social media in which someone or a group of individuals has adapted a doll to look like the kids that we see here in the hospital. Maybe it's an amputation, a G-tube button, maybe it's a brace of some sort. And you think to yourself, wouldn't that be the coolest job in the world? Like if it was a real job, right? It'd be the coolest job in the world, helping kids feel less alone, less scared, more empowered. Well, my name is Sami Rundo, and that is my job. I'm a certified child life specialist with a background mixed in development, psychology, medicine, and social science. We help children cope with the challenges of hospitalization, illness, trauma, loss, and bereavement in a way that children can understand. We utilize developmentally appropriate and evidence-based practices to help with their coping. So how do we do that? Therapeutic play, preparation, and education. Let me walk you through it. This is Kristoff. Kristoff is a doll that I use, or a toy that I use when providing education for nasogastric placements, or an NG tube placement. The first time that I used Kristoff was with a patient, we'll call her Ava, who was between the ages of 7 and 9 years old. At baseline, according to her parents, she had anxieties with medical encounters, and so they declined preparation, thinking that it would cause her to have greater fear, greater concerns, difficulty calming even before we began. So we didn't. It was a really difficult procedure. At baseline, getting an NG placed is difficult and kind of tough to watch. For her, I would almost consider it a traumatic medical experience. And the procedures that followed, even the smallest, were difficult. So at this point, we had built rapport, we had provided education, we had talked about assessments that had been made, and her parents were agreeable to have preparation when it was time for this tube to come out. I brought him in. Of course, Ava knew exactly who he was from the minute I showed him. And then she seemed delighted in the fact that he also had a tubie that went in his nose. She was able to explore it. She was able to look at why they had 2 Band-Aids rather than 1. I was able to shake his head back and forth because, sometimes it's hard to stay still while we're getting Band-Aids removed from our face. And she was able to identify, that's gonna make it worse. You're right, it is gonna make it worse. What do you think he should do? Should probably stay still. Do you think that'll help you as well? Probably. I agree. So she was able to work on getting those off. We were able to use detach all. She was able to see that that helps, sitting still helps, and then she was able to take the tube out. And then she wanted me to put it back in. And then she took it out again, and we did that a couple times. To everyone's amazement, not so much mine, when it was time to take Ava's NG out, she sat independently. She even assisted. It was like textbook. It was awesome. So let me tell you about Eli. The first time I met Eli, he came to the unit due to a portion of his lower leg having diseased bone. It's kind of small, but you can see 2 little green lines. That's where the bone was removed by the incredible surgeons we have here at NCH. An external fixator, or commonly called a frame, was placed, but you may also notice that he had a wire that goes through his heel and up his leg. For 3 months, we told Eli, do not walk on this heel. Do not walk on this foot. He agreed. When I met him again, 3 months later, he had the wire removed, but the frame remained. We showed him pictures, we talked him through it, we told him it's okay. Now Eli's 5 years old. So what do you think he said when we said, go ahead, get up, it's okay. We showed you that picture, we talked about it. He was like, yeah, no, I'm not getting up. It's not safe. The frame is still here. And the frame was still there. That's a really abstract thought. So I brought Ken. Ken has a Lego external fixator. This was not an easy one to make. But I can put it back together if it falls. On your left, you will see the fixator we used during Eli's first admission. He was able to explore it, he was able to touch it, he was able to take it apart. It was helpful. So when he came back and he could not make the connection that it was somehow different, we brought Ken back. We removed the lower portion of Ken's external fixator. Eli was able to touch Ken's foot as we touched his. He consistently referenced back to his fixator, to Ken's, back to his, back to Ken's. And then he got up with his dad. It was progress. As a child life specialist, yes, these dolls and toys are cute, and they can make it feel more normal. But we utilize these toys as tools. They're accompanied by developmentally appropriate language, continuous assessment of needs, and an adjustment of the information that we provide based on the dynamics of the room, based on them. It's incredible to see the change when working with these kids. Now, some people would believe that providing this education, again, only in sight sphere, it doesn't need to be had. If we just do it really quickly, it'll be over, it'll be fine. The evidence tells us a different story, and the why does as well. According to the American Academy of Pediatrics, roughly 50 to 75% of children enter the preoperative experience with anxieties. Those anxieties then have associations to post-operative outcomes. This includes delayed discharge, increased use of medication, increased use of providers needing to see them, an increase of the perception of pain. As a child life specialist, it's incredible to be able to have this impact at Nationwide Children's Hospital. It's incredible to be able to make this impact to improve better outcomes, not only for the kids and the families that we see here, but also for the institution. Now, to be clear, toys as tools and play is a portion of our job. And not every day is the most fun or the coolest. Some days we are a calm support for kids in excruciating pain. We provide coping strategies for a kid who's preparing to lose their hair. We provide education related to end of life. We support siblings who are never able to meet the new baby. And we do memory making of a life too short. When needed, we provide education and language to parents as they face their greatest fear. A conversation about the death of their child to their surviving children. A conversation no parent should feel equipped to have. Over the holidays, another child life specialist and myself worked with a family, 5 siblings ranging between the ages of 3 and 11, who experienced a traumatic and unexpected loss. Working as a guide to this family, we provided education to each of them on what it meant to be brain dead. We facilitated memory making with handprints, like the ones that you see here. And we assisted them as they approached bedside to talk to a sibling who looked nothing like the sibling they know, saying their final goodbyes. This is the part of the job that I call a great privilege. To walk hand in hand with families as they experience the full depth of what it means to be human. As a child life specialist, we might bounce from one room where a family is facing their toughest challenge or greatest defeat to the next, where we're celebrating a milestone we never thought we'd reach, literally. And then in the next room, playing, because play normalizes this environment. It's intentional. Play is how children explore and learn, and it should look silly, and I hope it looks silly because it is fun. Play is the work of childhood. Play is how children learn how to impact their environment. It's their language. And according to the late, great Mr. Rogers, play is often talked about as if it is an escape from serious learning. But for children, play is serious learning. It's the work of childhood. We do it because we care. We do it because it is so needed. We do it because it is the coolest job in the world. Thank you for listening.